afternoon, depending on where you're tuning in from. If it's from the Netherlands, it's in the late afternoon, and if you're from the Boston region or maybe somewhere else in Eastern America and you're tuning in, you're probably here in the morning, and you might even have been getting up quite early if you're on the West Coast, and it's probably 6 or 7 in the morning. Sarah and I are going to host this webinar. Sarah was just logged in. But we did run into some technical troubles, so I'll just start the webinar, and I hope Sarah will be able to tune in soon enough. And well, let's start with a general introduction of this webinar and what we're going to talk about. My name's Louis Antema. I'm a healthcare psychologist in the Netherlands, and I hope everybody is hearing sounds. I hope it's all working at the moment. If you can confirm it with a thumbs up. Yeah. Great. All right. Cool. So my name's Louis Antema. I'm a healthcare psychologist in the Netherlands, and I've been working in hospitals, I think, for the last 7 or 8 years as a psychologist, specializing in chronic pain in my last hospital. And it was about 3 or 4 years ago when I met Margriet Venema there. She was doing a master's in digital health innovation, and together well, you could say I was already working a lot with chronic pain. And given the direction of digital health innovation, Margriet really pointed my efforts and our efforts combined towards the population of chronic pain, because there's quite a lot of issues within the population of chronic pain. And the area of my expertise is mainly focused on how we educate patients on what chronic pain is and how we can train them to expand their skills on how to cope with chronic pain. And as we can see in guidelines, there's quite a lot of, you could say, quite a lot of focus on both educating patients on chronic pain and teaching them coping strategies. And when we look at the statistics on how often that is applied, we see that it's not often applied. And it made us think about innovating in that direction and seeing what we could do to actually improve the education and the training in strategies to cope with chronic pain that we teach patients. In the end, it came to Reducept, a virtual reality application that we are now launching with XRHealth in the United States. And as soon as Sarah will be joining, we'll be talking more about what XRHealth is and what Reducept itself is and how it can be of value in the treatment of chronic pain. So, to kick off with, and I hope Sarah is able to join soon, I'll switch to the part of the program where I will talk more about Reducept, and we'll just switch it around a little bit, where Sarah will be able to talk about XRHealth later on more, and I'll explain more about what Reducept does and what our mission is and what our view on chronic pain is. And to do that, I will use some slides. And a question from Jessica in between. I see we're definitely recording this for future generations, but also yourself, if you would like to watch it later, watch it back, or share it with coworkers, colleagues, or patients. So I'll share my screen right now and start with a little presentation on Reducept itself. So I already talked a little bit about Reducept. We're a company in the Netherlands solely focused on the topic of chronic pain and hopefully improving the treatment of the patients who suffer from chronic pain. So if we look at the problem of chronic pain, and when we say pain is chronic, we mean that the pain has been lasting for a period longer than 3 months' time. So it should impact someone's life for longer than 3 months, and it often impacts your work life, your social life, or your private life. So you'll often hear that people will be saying, like, I haven't been able to do my work as I used to do before, or I haven't been able to maybe do my hobbies as I used to do them before, or do the housework, or meet with friends and family. So it often has quite a severe impact on our social lives, our work lives, our private lives. When we look at the problem of pain, we see that about 1 in 5 people, that's quite a lot, in Western countries suffers from pain, chronic pain at this moment. So there's a large group of people that are severely impacted by chronic pain at this moment. It's estimated at 1.5 billion people worldwide. And in Dutch, that's 1,5 miljard. So that's quite a lot. And when we look at the people that suffer from pain, we see that about 1/3 of these people suffers from severe chronic pain. And that's when your pain score has an average that's higher than 5 for these last few months. What we also see is that many people with chronic pain suffer from chronic pain for a long period of time. So about 81% of patients suffers from chronic pain over 2 years already. So we see that it's a very, you could say, big problem with the amount of people involved. And for many people, the problem is quite severe as well. Many people who get chronic pain don't, well, you could say, get over it quite quickly. So only 20% is able to be helped within these 2 years. And if you have any questions in between, you can ask them in the chat, and I'll try to give you an answer as quickly as possible. So you could say it's a worldwide issue, and we see it in Western countries, in Europe, but also in America, that chronic pain is very persistent, but also very frequent. So interestingly, we're talking about virtual reality, digital therapeutics, and chronic pain today. And we see that quite a lot of people who suffer from chronic pain are, you could say, enthusiastic, or at least willing to try these types of solutions. So we see that within chronic pain, many people who have chronic pain are still not satisfied with their current treatment, and it's hard to find the right treatment or the right mix of treatments, you could say, to really feel helped with the chronic pain. So we see that many people with chronic pain are very open to receive new types of treatments, also e-health, and have positive or mildly positive expectations. And when we look at, the use of the health system, we see that chronic pain is quite an expensive problem when we look at it from a broader perspective. So when we look at the healthcare costs involved, and for example, visits to doctors and specialists, it's quite an expensive type of care. So, for example, in Europe, we often see that the care that is needed for chronic pain is more, for example, than the care for oncology and cardiology combined. So if you imagine that, you can imagine it is a huge problem, not only for the people involved, but also for the healthcare system. So a question in between from Gerda, if this can be viewed back with other patients, definitely. And if you're interested in the topic, at reducept.com or reducept.nl, you can find more webinars on the topic. We often organize them. So if you really like this, you can become, for example, a member of our newsletter, and you'll get updates when a new webinar is streaming. We organize a lot of free events and webinars for both practitioners and patients. Let's see. I see Sarah is still having some issues. Let's try to fix them a little bit in between. I'll just send her a short message. There we go. Sorry for the technical mumbo jumbo, but just getting back to the presentation and the definition of pain, because it gets interesting here, I believe. I mean, it's interesting to know that pain is a huge problem. I think most of you knew it. You might have been surprised by the scale of it. But when we look at the definition of pain, we see, and it's been changed very slightly last year, but we see that pain is an unpleasant sensory and emotional experience. And it has to do something with tissue damage. And it says here, and it's very vague. It says it's resembling or associating something that's resembling pain or tissue damage or potential tissue damage. Um, in the end, we say that pain is the thing that you feel, and what we know with modern pain science is that our brain creates pain when it senses danger, and this is a combination of both physical sensations and an emotional interpretation. So, looking at how pain arises, and I see we've got a question in between. Question from Sarah: if we're able to offer more of our webinars in English, I hope to do so in the future. So we've been available in the Netherlands, and we're joining with XRHealth to become available in the United States. And if all goes well, we hopefully, at least I hope so, will be organizing a lot of English webinars. And if you have any requests, you can always send us a message. And well, getting back to pain, we see here, and maybe you can see the mouse moving as well. Is that possible? I'm sharing my screen, so maybe. Well, on the upper left, you see the image of a man that's putting his feet in the fire. And that's an image that was drawn up by Descartes, a French uh, philosophist. Well, you probably know what I mean. And I think it was pretty smart to say in the 16th century that pain is when a sensation travels from the place where you feel it all the way up to the brain, and your brain is making an interpretation. And I think for many of us, we still see this relation as a sort of one-on-one relationship between some sort of damage arising in the body and our brain creating pain. And Helene is correcting me here. It's a philosopher, so thanks, Helene. And Descartes, I mean, I think it was pretty smart already to say, like, hey, there's something going on, and these signals will be transferred to our brain, and our brain will create pain. And like, well, the longer you put it in the fire, the more pain you'll probably feel. Well, and that, well, I think that image is still sticking with a lot of us, and it's a very medical explanation of pain. And we know nowadays, and I think the last 20 years, there's been a huge evolution in pain, understanding of pain and pain science. And we know right now that if you put your foot in the fire, I mean, we're 500 years later, but this is still happening. People are still putting their feet in fire. So that hasn't changed, but we know what happens right now. And that's that we say the signals that are coming from our feet, we're calling nociceptive signals, are traveling indeed up towards our brain. But then our brain is interpreting these signals, and the interpretation of these signals is what is going to create the sensation of pain. And that's what has changed, because we know that the interpretation of the signals will be very different from situation per situation and even between persons. So, me putting a foot in the fire and someone else doing it at the exact same time will lead to a different result in pain. So a nice example is for example they did research where they had a small hammer, and it was automated to hit someone's finger, and they did this with professional violin players and professional ballet dancers, and they did the exact same experiment with the exact same small hammers. They hit the fingers with the exact same speed, and the violin players reported higher amounts of pain and compared to the ballet dancers. And the explanation is as follows: that for a violin player, the fingers are much more important. So it's important that their brains give them more pain when something happens with their hands compared to ballet dancers, because they are much more dependent on how their hands function to be able, to do what they love and hopefully earn their money with, and that's playing the violin. So you can see also in this image, like prior expectations we've been having, where our attention is focused at the moment, how our mood is, and maybe even how our brain is structured, is influencing the sense or the pain that we feel. And This is a Dutch picture, but I'll translate most of it. And what we see when we look more to the psychological principles underlying this sensation of pain is that it's not information from the body only, so that's the upper left top, but also our emotions at the moment, what we're thinking, our cognitions at the moment, and how we are behaving. That's really shaping the sensation of pain. We got a question in between. Indeed, Sarah Ortiz. I hope she can still join. So I'll still be waiting for her to join and join the webinar. We'll just shift around what we'll talk about. I hope she'll join soon, Margriet. So you could say that chronic pain is a very a binary decision. And how we view it nowadays is that information from our body travels up to our brain, and our brain will interpret this information and it will try to see if there is a sense of danger involved. And it has many aspects. So it's like cognitions about the danger of the pain involved that can increase the sense of danger. Some emotions can increase the sense of danger. How you're behaving at the time can increase the sense of danger. And a very important factor where you're focusing your attention on in the moment can also increase the sense of danger. Well, and to give you another example, the example is quite familiar in pain education by now. A true story of a construction worker that stepped on a nail during construction work, and it was quite a big nail, and it came out right on the other end of his boot. So he stepped on a nail, and you can imagine the guy was screaming in agony when he saw the nail coming right out of the other end of his boot. So his colleagues were like getting towards him and asking if he was okay and if they needed to call an ambulance. And he said, "Yeah, it's hurting a lot." So they called an ambulance. They got him. Well, he got some drugs for the pain, and during surgery, the surgeon cut open his boot, and when he saw the nail, he just fished it like right out from between his toes, so that the nail was stuck between the toes of the construction worker. Even though this guy had been in agony for the like hour or hour and a half before, he was able to get to surgery. So what happened here is that we see in this context that there's not a lot of information from the body that was convincing the brain to create pain, but there was a lot of emotional and cognitive information that actually impacted the brain to decide to still create pain. I see Sarah has joined.
Finally, I'm sorry.
Finally. Hello, Sarah. Welcome back.
Hi.
I'll just finish the slide, and
Okay.
I've been doing a short introduction because I know we were going to do it later on. So I've
Yeah.
been giving
No, that's
people
fine.
an introduction mainly on the psychology of pain.
Perfect.
And well, with this construction worker, and you might know the story, Sarah, of the construction worker that stepped on a nail, but he was in a lot of pain, but the nail was actually stuck between his toes. We see that all the cognitive and emotional and attentional information was focusing on this sense of danger. And if we go back to the definition of pain, we see a very nice example here of pain being a more emotional experience where there is no actual tissue damage, but a lot of potential tissue damage. And it's definitely we definitely cannot say that every patient with chronic pain has the same issues, but we see that the pain system and our nervous system is very sensitive. And over time, even though the body often heals, you can see that these cognitive and emotional and attentional processes are still in place and are still able to increase the sense of danger or keep a high sense of danger. And that pain as an output is still well, you could say is still viable and still happening, even though the damage in the body is repaired or is partly repaired, or is maybe not even the biggest issue, or has never been an issue, because we have a lot of people with pain that have been having chronic pain for a long time, but it's very hard to see what the actual damage was, even if it maybe hasn't had been there at all. This is what we focus on with Reducept is like how can we influence pain by influence what we think, what we feel, how we direct our attention, and how we behave. And I'll leave it at this just for now. So we can get back to Sarah and also get back to your introduction, Sarah. I did a brief introduction of myself and what Reducept is, and it's been a lot of theory so far, but that's because I'm really fond of the theory of pain and psychology. So let's see if we can, yes, switch
Awesome.
to a double view.
Awesome.
And
I should have gotten my presentation sent to you. I emailed it to you.
Great. Let me see if I can open
Anyways, while you're pulling it up, I'll introduce myself. I'm Sarah Ortiz. I'm a doctor of physical therapy with XRHealth in the US. I've been working with XRHealth for about a year, and it's really exciting because it's new innovative technology using VR to help with chronic pain, which is a big problem in our country and around the world, as Lewis has been dealing with over in Europe.
Yep.
So sorry about the technical issues. It is not a happy day with technology for me. All right. So chronic pain, it's a big thing within our country. A lot of people suffer from it. It's a term that we use. I'm kind of going to give a general background about pain and kind of go into chronic pain and the treatment kind of options that we currently have. Pain is just a term that we use to describe any uncomfortable sensation that we have within our body. It can come from different points. It can come from different points in our body, and we feel the sensation within our brain. It can also come from the top down, from the brain into the body as well. Is there any way for me to control this, Lewis?
Yeah, no, I know. I'll share my screen and I'll be your assistant for now. So you can say next slide, Louis, and I will click.
Perfect. All right, go ahead and go to the next slide for me.
All right, there it is.
All right, yep. So like I was saying, it can come from any injury. Doesn't necessarily have to come from an injury. It can come from an illness. It can come from hypersensitivity of nerves in the body, from pain conditions. It can also come from, like Lewis has been researching and working on, from psychological disorders. So it can come from the brain down into the body as well. Pain is very highly subjective from person to person. As we all know, people describe it very different ways. They perceive different intensities. Comes and goes, can be constant, generalized, annoying, different descriptors like stabbing, dull, achy, and such. You can go ahead and switch. All right, so we classify our pain in a couple different ways. So we classify it mainly by time length. So acute pain is anything that's like less than 6 weeks. Usually comes from a specific injury, twisting your ankle, cutting yourself, stepping on a nail, anything like that. And then, so that usually lasts less than 6 weeks. Subacute's kind of this middle timeline that goes from 6 weeks till we hit the chronic threshold of about 3 months. And 3 months is when we start to classify pain as chronic. It can come from a specific injury that just lingers for a long time. It can linger beyond the initial injury. It can also come from different types of medical conditions like fibromyalgia, cancer pain, GI problems, things like that. Next slide. So like I said, we classify pain based on time length, but we also classify it on kind of like the source. Okay, so nociceptive pain is pain that we perceive from our sensory nerves. Somatic nociceptive pain is from like joints, ligaments, bones, and such. And then visceral pain is more from like our internal organs that refers out to our body, and that's how we perceive visceral pain. Neuropathic pain is pain that comes originally from our nerves. Okay. And that's where you get nerve irritation. That's how a lot of like our chronic pain comes around, neuropathy, phantom limb pain, things like that, which is actually a big part of VR has been helping with phantom limb pain as well, which I'll kind of discuss later on. Next slide. There's also psychogenic pain, which I know Lewis will talk a lot on, so I won't delve too deep into this, which is caused by psychological disorders like depression, anxiety, things like that. This comes from a very different approach and doesn't have a physical origin. So that's usually when you do mental health counseling, VR treatments, things like that. And then we have idiopathic pain as well, which is pain that kind of pops up out of nowhere, can't find the cause, doesn't really have a specific physical or psychological, and it's very difficult to treat, and it has a very multifaceted approach. That's like fibromyalgia and things like that. All right, so there are a couple different things that can cause pain, and these causes can always cross overlap and such. So sometimes you can start with like a structural injury, like I twisted my ankle, but I go to the doctor and the doctor says nothing's wrong or it's all healed. Then we can kind of graze into other type of causes, and you start to develop some psychological dependence because you become oversensitive to the pain, or nerve components start to be added into back injury that you've had and such. Right. So this is kind of like a current overview of the treatments of how we currently treat chronic pain. A big part of it is pharmacological medications, injections. A lot of doctors will also start to incorporate some nutrition modifications because of current research that has shown that some diets will increase inflammatory factors we produce in our body. And so we do some modifications in order to kind of decrease that as well. We do a lot of physical and occupational therapies. I treat lots and lots of chronic pain. And then from the other aspect of, like, I deal with a lot of physical injuries, but Lewis deals with a lot of chronic pain from the psychological aspect and mental health counseling and such like that. Next slide. All right. So this is kind of a general list of any pharmacological medications, injections. So you have your normal over-the-counter medications, Tylenol, ibuprofen. Then you have your prescription ones of like muscle relaxers, opioids, sometimes topical analgesics, like your creams, like your Icy Hot, your BioFreeze, your Voltaren gels, things like that. Excuse me. Anticonvulsants and antidepressants are sometimes prescribed with psychological pain to kind of help with those conditions. We also do fluoroscopy guided injections for usually for specific like nerve pain, epidural injections, cortisone injections in the low back and the neck and such. And we also do trigger point injections as well with like lidocaine medications. So nutrition modification, chronic pain is often associated with inflammatory factors in our body, and Western diets, like in the US, we're heavy on refined sugars. We're heavy on red meats, processed food all the time. And this will increase a lot of our pro-inflammatory factors that are naturally produced by our body. So this is sometimes approached as a way to help chronic pain, especially if you've tried all the medications, you tried injections, and it's just not working. This is a good way to kind of help manage your chronic pain as well by changing your diet to more fruits and vegetables, more omega-3 fatty acids, fish, avocados, things like that, in order to decrease some of that production and decrease the irritation of that chronic pain that people have. Gut microbiome can also help with chronic pain as well, because a lot of patients have tried to probiotics to kind of help their digestive system and not let things sit in there. Inflammatory factors kind of absorb and stuff like that. And this is a very new area of research as well. And so this is still being researched a lot, but it's definitely coming into play along with other new research treatments. So physical and occupational therapy. This is kind of my area of expertise. All right. I see a lot of chronic pain patients. And we work a lot with chronic pain patients from chronic injuries. Sometimes we see a lot of chronic illnesses, but our biggest thing is I can't affect the structure of something. So we try and adjust the function and how well things work. And what happens a lot with patients is they become very anxious and very tense and are afraid to move because of their pain, and they're afraid they're going to cause more damage. And pain doesn't always relate to physical damage. So we have to teach these patients with different exercises, different techniques. Is we will do like movement exercise and be like, let's just gently move a little bit, Does that increase your pain? Oh, no. So it's not going to do any damage to move a little bit more. It won't necessarily make your pain level always go down. We try and get it to go down, but at least you're not afraid to move and you're able to do more and live more in your life. We also do strengthening exercises, balancing exercises for safety, and being able to better perform your activities of daily living. Functional activities. I want my patients to be able to go out and live their lives. I don't want them to be afraid and not to go out and do something because it's going to hurt or they're going to get stuck somewhere. It's like they go out and they want to do something with their family, but they know that it's going to hurt, so they're just going to sit out. And then it perpetuates anxiety, puts a little depression in their life. And so it kind of perpetuates this chronic pain cycle. So we try and educate them a lot about their pain, trying to get them move more, be able to do more, and be able to live their life a little bit more fuller and make them more happy. So then they're not perpetuating this chronic pain cycle of the anxiety and the depression and making everything more amplified. Next slide. All right, so this is kind of like a brief overview of the psychological and mental health counseling, which I know Lewis will kind of touch on as well with Reducept. This is his area of expertise, not mine. So this is used a lot to treat patients' psychological disorders. They work on trying to change negative behaviors and improve problem-solving skills and coping mechanisms as well. Two of the main approaches that I found within my research is acceptance and commitment therapy and cognitive-based therapy, which I know Lewis will talk a ton about. All right, you can go breeze through that. All right, so other alternative treatments, which patients do try, and they don't have a lot of scientific research to help with this, to kind of support this, but it's more anecdotal evidence. Some patients find it works really well for them. Sometimes it's kind of like, didn't really do a whole lot for me. But sometimes when you have chronic pain and you're in pain all the time, a lot of patients will try anything to decrease their pain, live their life a little bit better. So these are some of the different alternative treatments that they will also try as well. You can go into this. So big thing I'm going to talk about is VR treatments within XRHealth and how we use them within XRHealth. So virtual reality treatments help a lot with chronic pain by refocusing the brain's attention away from chronic pain. So when a patient's doing like brushing their teeth, taking a shower, washing their dishes, walking around their house, they're like, I'm doing this activity, but it hurts so much, it hurts so much, it hurts so much. Because they're used to that environment and it's real life and they know it's going to hurt, so they focus on it. When we put them in virtual reality, it puts them in a new environment, a new fun environment that they can play games in, they experience new environments. Like we have an application that has tours of Mount Everest and takes you through a deep sea dive with dolphins and things like that. And this kind of removes you from daily life and puts you in a new environment that helps distract the pain away from the brain. And so they can do things and move more without focusing on their pain. We use it a lot to also educate about pain as well and to kind of change the way they think about it. So they're obviously going to have pain. We can't always, as a physical therapist, I always tell my patients, is like, my goal is to decrease your pain. I can't guarantee it. I'll do the best I can, but I want you to live a more fuller life. So we try and educate on how to do things around this pain, and the VR is a good, helpful tool with that because we're not afraid to move. We play games, and when they're in the games, they realize, oh, hey, I can do more. I'm distracted. I'm having fun. I'm not painful while I'm reaching for this balloon that I'm trying to pop and things like that. So it's become a good tool, especially we use it in XRHealth. It's a really good tool, and my patients find more engaged with it as well. And when I use it in conjunction with my traditional exercises I normally do to kind of help flexibility and strength as well. But using this, they're like, oh, hey, I didn't realize I was in pain and I'm doing this fun game. I like this. I can do this more during my daily life. So this is a really good way for them new treatment technique to kind of get them away from that pain. Go ahead and go to the next slide, Lewis. All right. So this is definitely being researched, and the research coming out of this is really good. It definitely still needs a lot of research to continue to support it, but these are a couple quick research articles that I found. Stanford University did a quick little study of chronic low back pain and fibromyalgia. So they had 100 patients with chronic low back pain or fibromyalgia. They underwent 21 days of VR treatment, and they found a significant reduction in their pain outcomes. They weren't completely pain-free, but they had less pain and were able to do more of their daily activities, go out walking, perform their activities of daily living, grooming, dishes, things like that, with less pain. Now, there's also been a systematic review that I found that went over several different studies, and they found that VR treatment is very effective in treating acute pain and chronic pain. So we can do it with brand new injuries, and we can also do it with more chronic long-term pain as well. And they found that it does help with pain. Pain scales went down, functional abilities to do certain activities, functional pain scales went up, when functional activities went up, but it still needs a lot of long-term research to make sure that the VR is a long-term solution as well, besides just a short-term solution, since we've only researched this in the last couple of years. So it's definitely something that's up and coming. It's definitely something that has benefits, and we're looking forward to seeing what other research is starting to come out with this. So there should be a video in this if you hover over the screen, Lewis. So this is a testimonial from...
Ooh, not sure if this is going to work in this presentation. Is it on YouTube or not?
Let me...
I can look it up.
Let me see if I can pull it up for you. I'm not sure.
Yeah, I think I found it. Let me see if I can. There we go.
I got in a major truck accident with UPS, went into shock, mini strokes. These two fingers work, these ones weren't working at all. Now I can tie my shoes.
I think you can mute now.
You may think that's nothing, it's awesome. I'm realizing what I can do now because of this machine. And the machine is not just a machine. There's actually live people that help you. It's a perfect bond. I can't hold the smile back. When you can do something that you thought you could never do again, you have hope. You accomplish something. You are your own hero. You got to realize you need something to get there. This helps you get there. And in the privacy of your own home. I feel stronger. I get more confidence, which is the big thing. With this machine, I'm still seeing things that can apply for my disabilities and so much other. Look, that's a miracle, all right? That's this program. Some days the pain is so great, I have to be in a wheelchair. I cancel everything. Now I can go for a walk with my friends. I talked to them while I was walking. I was happy. I was out. I was socializing. I felt great. I thank you for this. I was socializing. I felt great. I thank you for this.
All right, so that was John. He was one of our original patients with XRHealth, and he loved the XRHealth. He loved the platform. He loved being able to play games. He was able to get back to a lot of his activities, and like you said, helped his pain a little bit, but he realized he was able to do more and accept his pain and move past it a little bit to live a more fuller life. You can go ahead and change the next one. So these are some of the current VR applications, like Reducept, like Lewis will talk about. At XRHealth, we currently use Luna and Relaxate. Luna is another pain management meditative type application we use for hot flashes, pain management, and breathing techniques as well to help with relaxation. And then our Relaxate application is also for meditation, and we use for diaphragmatic breathing to help decrease a lot of that anxiety, a lot of that tension, muscle tension, in order to calm down a little bit and not decrease some of your pain as well while we're using it. And these are some of the other applications that are also within the market. All right, so chronic pain, like I've talked about a lot, it's an ongoing epidemic around the world. We're continuously researching. At XRHealth, we use a lot of VR. We are doing a lot of research on our own VR applications, as well as how they affect our patient outcomes and how they affect our patient's pain level. And it's definitely something we want to continue to research so we can benefit the most out of our patients with chronic pain, because this is a huge population that we can help affect and live better lives. All right, and then these are some of the testimonials from some of our other patients that love, and we see everything. We see everything from, I see chronic low back pain, I see fibromyalgia, I see neck and back surgeries that are like 10 years old and still have pain from their surgeries. We see in XRHealth, I have other clinicians who see Parkinson's disease that we help a lot with, and MS with a lot of patients, and pain and things like that. So it's not just one small group. We see a lot of things that see everything with pain, not just chronic low back pain, but all types of pain and all types of diseases and diagnoses as well. All right, and then I'm going to hand it over to Lewis to kind of introduce and go over Reducept and review that.
Yes, thanks, Sarah. Well, I think we're switching it around a little bit, but I think a great introduction. And if there's time, I think it's definitely good to have some discussion going on, because
definitely.
I think well, what we've seen so far with many, the application of psychology within chronic pain is, as you told, traditionally been mostly focused on, we could say, like psychopathology that is existing besides the pain itself. And I think also in my clinical experience, when I started as a psychologist treating chronic pain, I found it really difficult to like help people. But what I noticed after I think a couple of months, maybe even a year, is that this sense of danger, like the higher the sense of danger a person has, and that's often an emotional and subconscious process, but like you could say the more danger the brain is interpreting, the higher the output of pain is, and that's independent of also the cause of the pain, you could say. So it could be nociceptive pain that's, like, you could say that's getting bigger and bigger because of emotional processes going on, or neuropathic pain. And I think the mission that we have with Reducept is to really see, like, how can we make the brain interpret what's going on with a person as you could say, like, less of a danger. And if I get back to the presentation, I think this picture shows it nicely. And if you have any questions in between, Sarah, please ask, or within the audience right now.
Sure.
So I think what is nice about this picture, and it's sort of what we call the onion model, is that there could be tissue damage, there could be nociception, neuropathic pain, but even in this case, your interpretation of your problem could make you experience pain as a bigger issue, or could even make you experience more pain. So you could say that two people with the same tissue damage have a very different maybe lifestyle interpretation of their problem and coping style, in which the one person might say, yeah, my pain's an average of 9 out of 10, and another person will say my pain's an average of 3 out of 10. And what we're trying to do with Reducept is, try to, you could say, minimize the sense of danger that the brain is processing, and hopefully decrease the sense of pain. And as you said as well, try to decrease the pain as much as possible. And it's not always possible with one strategy to decrease all the pain. And I think it's very often a combination of strategies. And what I love about collaborating with XRHealth is also the availability of different, you could say, different strategies and different VR interventions with different theoretical backgrounds as well. Well, looking at why such interventions such as Reducept are needed, and I talked about it briefly, is that in guidelines we talk a lot about pain education and pain management, and when we interview patients, and this was a study that was done in Europe on a broad range of patients in a broad range of countries, we see that about 4% of patients is reporting they've actually they got pain education and they got like a pain management training, whereas often like 80% of even more than 80% of people are reporting to have received medication. And if we look at most guidelines, they will at least state that, well, patients should get the chance to be educated and should get the chance to learn to regulate their own pain before you jump to more, you could say, severe interventions, such as providing medication. But in reality, you could say it's the opposite. So I really hope that with XRHealth, we can make a difference in this case, and it will be something of a long run. But I really hope that we can educate patients on pain and how to manage it, and even if you're going through, you could say, medical procedures, it can be really helpful to better understand how your pain system works, and even then, it can be really helpful to know strategies and know, you could say, techniques to influence your own pain level as well. A lot of evidence for different types of strategies, not always that they, in the sense that they're decreasing pain a lot. So decreases of pain are often found in these researches, and it's varying. We often tend to focus more, especially in the short run, on improvement of quality of life. And we see a lot of positive outcomes for both ACT, CBT, but also there's a lot of research on mindfulness and eye movement desensitization and reprocessing. That's a traditional trauma therapy that's very supportive of applying these therapies for chronic pain, and not only for people who have chronic pain and psychological issues, but also people who just have chronic pain and have been suffering from it for a long time. Now, looking at Reducept, and there's a lot of more information to find on Reducept online. If you want to look at more movies, you can definitely look us up on YouTube, for example, or just visit our website. But what we're doing with Reducept is that in our virtual reality training, we're combining different therapeutic strategies that teach patients to regulate their own pain. So, for example, one of the first elements in Reducept is a part of the gameplay where people can actually shoot their own, you could say, their own nociceptive signals. So often people call them pain signals, and we've asked a lot of patients how their pain looks and how they would view it, how they visualize it. And by shooting the pain away, you could say, in virtual reality, it gives patients an emotional sense of control. And I think what's great about virtual reality is that you are in a different reality, and especially the emotional part of our brain has a very hard time to understand what's going on, and it will often just interpret the situation we're in virtual reality as a real situation. So by doing these exercises, we're giving patients more emotional control over their own problem, and by providing this emotional control, we hope that the sense of danger that the brain is interpreting is slowly decreasing. We're doing a lot of research right now. Last year, we had a larger scale research with 55 patients, in which 74% of the patients showed that they actually their pain improved in daily life, and that's what we're aiming for with Reducept, is to teach patients strategies they can apply in their daily life. So many patients that use Reducept for a while, they will tell us I was standing in line for the counter, and the pain shot up in my back, and I just closed my eyes for a couple of seconds and just shot away the pain, and I felt better. I don't know how or why. And this is really nice, because this is when patients learn to recreate the exercises and learn how to, you could say, decrease this sense of danger instantly in situations in their real life.
Quick question, Lewis. Do you find that patients, how do I put this? Even if they don't quite understand the science, do they still find benefits with Reducept?
Yeah, definitely.
Patients are like, I don't understand how this works, but
yeah, no, that's definitely. So the way I see chronic pain is that part of the problem is emotional, well, our emotional brain is what we often also call our subconscious brain, or at least part of our subconscious brain. And you could say that our emotional brain is constantly trying to make the decision, is this situation dangerous for me or not? Is my body in danger right now or not? And this is not something we're conscious of. And I think the great thing about using virtual reality is that you can provide very emotional experiences for patients, in which they, on a rational level, will say, like, I don't know what happened. Maybe I have one fun experience. There was a doctor, and well, she was having a look at Reducept, and she was very skeptical and sort of like, I don't know. I mean, people just have pain, right? There's just something wrong with the body, and what is this VR going to do? But she did want to give it a try, and she played the part where she was shooting away her own pain, and like after 5 minutes, she put off the VR headset, and she was flabbergasted. And I was like, okay, what was it such a bad experience? And she said, like, no, I broke my ankle like 4 months ago, and it still hurts, but like it really hurts less than just a couple of minutes ago. And I can't explain what happened. So I think this is definitely a strength of Reducept, that what I found in many of my therapies is that it can be really hard to get people to actually, well, maybe do or try to do more like psychological exercises and strategies. And Reducept is, I mean, it's attractive for many patients, because it feels like, hey, I just put on this VR headset and it will do something with me. And whilst they're doing it, they're being drawn into strategies that will actually trigger something they can recreate themselves to manage their pain. So I think I think it's an easy way into the psychology of pain as well, because it often feels quite, for many patients, it feels quite heavy to like be referred to a psychologist, and we don't think lightly about it. There are not a lot of psychologists available, at least in the Netherlands. It's just not like there's long waiting lists. So I hope this is definitely an easy way into the psychology of pain.
Okay.
And also more than a distraction. So also in our research, we've seen that from the people that feel helped in their daily lives with Reducept, we let them play Reducept for a month. And half of the patients said, like, hey, this is something I would like to continue at home. So they keep the VR headset and they keep playing. And the other half said, like, hey, I feel like I've gained the knowledge and the skills to cope with pain better in my daily life. And I think that's great that you're able to, like, just, well, stop doing a therapy, or maybe do it just like I use my mindfulness app maybe 2 or 3 times a week, but no longer dependent on a treatment, and feeling like better able to manage it yourself.
Okay. Do you ever have patients, like, once they've gone through the whole Reducept protocol and treatments, how do you kind of set up your patients for long-term success once they don't have the VR headset anymore?
Yes. Well, I think what we do with Reducept is we also train practitioners to apply Reducept, and besides the VR training, we offer patients a lot of materials, so they get their own workbook to work with, their own exercises. If they would like to, they can keep getting exercise access to also online exercises we offer from Reducept, and we hope that, by applying this protocol, patients internalize as much of the skills as possible, and if they ever need anything, they're able to find it on our website, or if they would like to get a really affordable patient how do you say it, patient license as well. So if patients really say like, hey, I would like to keep using this, then they can continue with their own license, because we don't want to cut patients off completely if they would like to continue using it. Yeah.
Okay.
Yeah. I think we've covered most of an hour. I have one thing to share here that I can talk about a little bit more, and we did cover the topic already, but I think what is the power of what we offer with Reducept, and what's different from other solutions, and that's not to say that Reducept is the solution, but that a range of solutions can really help someone with pain. But the creation of pain really is, for a high part, an emotional process, and I think influencing this emotional process to really decrease the sense of danger that the brain is experiencing can be helpful for a broad range of patients. So also, if we look at the patients that are applying Reducept, or that have been in my own therapy, some of the patients have really well explained causes of their pain. So some of them have been having cancer for a longer period of time, or they're having a really clear diagnosis or neuropathy. But even then, you see that, I often say any pain is partly physical, and there's also always an emotional component. And for some patients, this emotional component is quite large, and the physical component is smaller. For some, the physical component is large and the emotional component is smaller. But there's always room to look at the emotional component of pain, and see if there's if there's any possibility to decrease the sense of danger the brain is experiencing. So I'm really curious how this is going to land at XRHealth. And we'll be going into our beta soon, and training the professionals, so they will be able to use Reducept. And looking forward to see how that goes, and how it also lands with our with the first American patients there.
Yeah, we're about to roll it out and getting some pilot patients going here at XRHealth.
Yeah.
Very exciting.
Yeah. There are still a couple of questions. I think one of the questions is there experience with complex regional pain syndrome? I don't know if you have experience with XRHealth and CRPS.
I have not worked directly with CRPS at XRHealth. I have a little bit of experience in my previous clinic that I used to work in. But it's a lot of the CRPS is because it's gone way past an injury, and it's the pain portion that's been hanging around forever. So it's definitely something we can approach at XRHealth with using Reducept and Luna and Relaxate to kind of help deal with the emotional part of the complex regional pain syndrome to try and decrease some of that pain.
Yeah.
It's definitely something we can work on.
Yeah, we have similar experience. And within the Netherlands, we collaborate a lot with physical therapists, and I think the way that XRHealth is set up suits Reducept really well, because chronic pain and I mean CRPS, but most chronic pain is quite a complex problem, and it's not just a question of okay, we're just applying this program. No, it's a professional that will look at the cause of the pain and say hey, it's probably good for you to get educated on pain and learn strategies to cope with it, and combining that, for example, with movement exercises. And that's what we see happening in the Netherlands a lot right now.
Yeah, it's kind of the same way we approach it here, is if we can get the pain down using the VR headset as well and getting kind of the emotional part down of the pain, and then we kind of promote more movement, then we can address it as well.
Yeah. Yeah, and I see there are some questions in the chat here as well about I think about Reducept and different types of pain. And I think the answer for most types of pain is that I can give is quite similar. That Reducept is focusing on the emotional component of pain. It's really trying to decrease the sense of danger, the emotional sense of danger that the brain is experiencing, and I think it's independent of a diagnosis. And also, when we look at guidelines, they often state that pain management, pain education should be applied for anyone who has been having pain for a longer period of time. And it can be a big part of the solution, and sometimes the part is smaller. That's hard to predict. And we're trying to do the best we can with Reducept to make the most effective brain training for chronic pain. I think that were most questions at the moment. We've also hit the 1 hour mark, which means we'll be closing the webinar. Thanks, Sarah, for joining and co-hosting the webinar.
Thank you, Lois, for having me.
We had some technical difficulties, but I think we managed it well enough. And I hope everyone has enjoyed the webinar. Follow us on XRHealth on LinkedIn or Reducept on LinkedIn. If you're interested in Reducept and our newsletters, other webinars coming up, keep an eye on our website, for example. And definitely the webinars we'll be co-hosting for the US audience will appear on the XRHealth newsletters and website as well. So I would say like, subscribe, win, and follow.
Yes.
And all such
you can
things.
find XRHealth pretty much on any social platform, and you can also find us on our website as well.
Great. If you have any questions to either XRHealth or Reducept, you can, of course, send us an email. In the case of Reducept, it's info@reducept.com. And what's it for XRHealth?
I think it's info@XRHealth. I think is what it is.
XR.health. Yeah.
Yes, I will give it to you so you can pass it along. I'll make sure.
All right. Thanks, and have a great day, everyone, or have a great evening.
Thank you for joining us.
All right. Bye-bye.
Bye.